We have the NECADE case of the week, number 3. We're going to call this the large amalgam overhang. So as we can see in this image here submitted by the doctor, there's a rather large amalgam overhang that may or may not be presenting itself as a clinical challenge. Before we get started, I just want to thank Mitch for submitting the case. This is definitely one of those cases that may appear easy on the surface, but is rather difficult for us to treatment plan and execute. So I want to talk a little bit about a phrase here, and the phrase in the blue here, when treatment planning doesn't fit into a box. So when we go to dental school, a case like this, if we were to be given the opportunity to do this, in some dental schools this would be referred to the residency programs. If we were given the opportunity to do this, the execution is where the bulk of our attention would be spent. And the treatment planning and looking at the pros and the cons of all of the different options is really not where our attention is going to be, because we are so focused on the execution. How are we going to do this? But the why and what those treatment planning options are would be largely decided upon by the preceptor or the overseeing dentist overseeing the case in dental school. But as we graduate, that decision-making process is transferred to us, and we may or may not have developed that skill in dental school. And I think this is a great example of a situation where we're likely to run into challenges when it comes to decision-making. Before I move forward, if we were to put 100 dentists in a room and there was a class 2 lesion that looked like this on number 30, 90 to 95% of the dentists in the room would agree on the execution required or what the treatment options are for that patient. But a situation like this, if you put 100 dentists in a room, you're more likely to get 200 to 300 opinions. I'm embellishing that a little bit to make the point that this is not very clear cut. And it's one of those situations that we have to agree that there's no perfect solution here. Any option we choose is simply just the best option that we have in our toolbox based upon our experience. But what I hope to do here is look at all of the options with a microscope in hopes to get a better sense of choosing a treatment option based upon maximizing the outcome while mitigating or minimizing the untoward effects associated with that. And this is one of those cases where there's a beautiful opportunity for us to unpack all of those. Before we do that, let's take a look at how the patient got here. So here we can see a horizontally impacted number 32. We can say there's bone loss on the distal here. Most likely there just was never bone formed at all based upon the cyst that was surrounding the developing number 32. But what it caused was a lack of connective tissue and bone on the backside of this tooth. Those two entities help protect against bacterial invasion into areas where we're likely to get conversion to anaerobic bacteria, which are more destructive to the hard and soft tissues in that area. So it's likely this was decay. It's hard to say based on this pan. That could be cervical burnout. But let's just assume based upon what we see here that was decay. The treating dentist likely removed the tooth, had the oral surgeon remove this, and then did their best to access this from the buccal and or lingual, and then treated with amalgam. The problem is that was a rather difficult endeavor by not going through the occlusal, and what we're left with is this overhang here. So let's take a look at the diagnosis. Before we talk about treatment, diagnosis is important, although we're not going to come up with a specific diagnosis because there is no diagnosis other than large occlusal, large amalgam overhang. But let's take a look at the problems. The first is this area of radiolucency here. And what is that? One might say that's decay. One might say it's nothing. One might say it's resorption, either internal or external or cervical. And some might say mock band effect. We know what decay is. We know what resorption is. In the lack of a clinical diagnosis, it might be hard to determine exactly what this is, but simply based upon the radiographic interpretation, I want to explore what mock band effect is. Mock band effect can be defined as a perceptual phenomenon in which the human visual system exaggerates the contrast between the adjacent areas of differing brightness. This creates the illusion, so not in reality, the illusion of a bright or dark band near the boundary of the regions, even though no such band exists in reality. This particular phenomenon is not a dental phenomenon, although it shows up quite a bit in dentistry. It's a visual phenomenon, but it plays a very significant role in treatment planning, especially in situations like this. To further understand what we're talking about, I drew in a yellow line of where the bone level is on this x-ray. As we can see here, above the yellow line is where we see the bulk of this entity, this radiolucent area. Below it, we have what I would call a normal root surface. Well, according to the Mach-Band effect, there's definitely a difference in radiolucency or radioopacity or radiodensity above and below that. And the great part is, a great reason for this is the fact that you have bone and root, where the bone is rather dense below the line, and above it you have no bone, and you have soft dentin and cementum. And what that can do is give the appearance that there's decay here. Let's come up in this area here, although not as obvious, in great part because there's more tooth structure here. So the increase in tooth structure gives us the appearance that there is more, the difference between this area here and this area here is less, in great part because there's more dentin here compared to here. As the bone drops down more and more, because of the tapered nature of the root, we're going to have a greater difference between these two areas than these two areas, which gives us the appearance that there's decay here. You add on top of that a rather radio-opaque amalgam and then a radiolucent pulp, and you have an area that just looks like there's a problem here. To drive the point home, look at this area here. So the area of cervical burnout compared to the more bulbous part of the tooth where there's more enamel and more dentin, there's a difference between the two here. The difference is there's not a strong delineation here. Bone does that for us. So bone, when it's undulating in certain areas of the tooth, different from what we're used to seeing, can give the appearance of decay. So when does Mach-Band effect appear? Cervical burnout, we all know what that is. Rather well exemplified right here. As we can see, this is an area that's commonly misdiagnosed as decay by young dentists. We know decay starts, for the most part, starts at the contact point, works its way down. Well, we don't see decay here, so we're not going to have decay here. Could it be cervical burnout? Yes. Could it be a cervical root resorption? Possibly. But I think we have a trained eye to know exactly what that is based upon what we're seeing, cervical burnout. We also see Mach-Band effect adjacent to restorations. And I don't see any here. Well, yeah, right here. Mach-Band effect differs from restorative material to restorative material. But really what we're focusing on is Mach-Band effect when bone levels change and undulate, as we can see here. What's important to note, Mach-Band effect, again, is not a dental phenomenon, but it's a phenomenon of our eyes interpreting the difference between different brightnesses. The Mach-Band effect is further amplified in dental radiography based upon the fact that the density of what is being picked up by the X-ray is diluted. In other words, the X-ray beam travels through and only picks up radio opacity at 30% density or something in that arena. That further amplifies the Mach-Band effect. So how do we work around this? Again, a clinical interpretation might be something that's helpful, but let's just pretend for a second we don't have the advantage of having the clinical examination, or the clinical examination didn't show us anything of significance. In other words, we didn't get any soft areas with our Explorer. We didn't see any areas of decalcification. There was no inflammation and no deep probings. Well, to determine whether or not that is a clinical reality or just Mach-Band effect, we can add the additional view. This additional view doesn't show me the radiolucent area that I see here. I just feel that if this was a clinical reality, that we would see it in all views. but mock band effect tends to change as we change the angulation of the X-ray beam. So here we have the tissue coming up like this. We have a mock band effect above and below where the tissue supersedes the dentin of this tooth. We have another one right here, although this is less obvious. You can see how this is more radiodense down here than here. So again, the mock band effect shows up all the time, and as we become more astute clinicians and diagnosticians, we tend to not even think about it. But as a young clinician, it's super important to understand this concept so that we can kind of weed this out as an artifact and not necessarily a clinical reality. So what do we do here? We just talked a lot about diagnosis. We took a detour to talk about the mock band effect. But what do we do? What are the options, and what are the treatment planning scenarios that we can present to our patient? Before we do that, I think it's important that we talk about the problems. Again, this situation doesn't fit itself into a classic diagnosis like pulpitis or carious lesions, but it's just a set of scenarios that we can call problems. So let's take a look at what those are. An overhanging amalgam. Is that a problem? Maybe, maybe not. The amalgam purist might say that because amalgam is rather bacteriostatic or bactericidal, the alloy itself just lends itself to not allowing bacteria to live next to it, might say that this tissue is doing rather well or likely to be doing rather well. In my clinical experience, I've removed deep amalgams like this, and I've been rather surprised of the health of the soft tissue and the tooth that sits near it. This is just an exaggerated situation. So I personally think this needs to be addressed, but do know that if the overhang was, say, here, and we didn't have any clinical signs or symptoms, I might be more likely to leave that as is. One might say this is a perfectly good case to leave as is, again, in the absence of other clinical signs and symptoms. Here we have a deeply subgingival amalgam. We just talked about that. Essentially, how deep can an amalgam go? Well, amalgam is somewhat biocompatible, evidenced by over a century of use in people's mouths. I don't want to dive into whether or not this is healthy for the patient based upon its mercury content, but suffice it to say that from a tooth perspective and surrounding periodontal perspective, deep subgingival amalgams can perform well. We have significant bone loss on the distal. We could call that absence of bone because of the wisdom tooth that was there versus loss of bone, which was once there. But that's the description we're going to use. Then we also have the large occlusal amalgam here, which might further structurally compromise the tooth. One can imagine if we decide to create an occlusal access here to get to this amalgam, that in combination with the already large occlusal amalgam, that we might actually decrease the structural integrity of the tooth. Inability to probe the distal. It's just hard to assess whether this is healthy or not based on the fact that there's such a large overhang here. And lastly, we have a non-compliant dental patient. So we could have a conversation about what to do with the presentation with a compliant dental patient, but then you add on top of this a non-compliant dental patient, meaning somebody who doesn't show up regularly. How does that add to your decision-making process and what you're presenting to the patient? It's important. So let's take a look at a few restorative solutions. The first one would be we just reduce the overhang with a diamond burr or carbide burr. I would use diamond here just based upon what works well in my hands. But if we were to reduce this, we were to reduce the overhang, thereby improving the periodontal restorative interface, in theory. One reason why I don't like that, that's rather hard to do. This bulbous nature to the crown might prevent us from getting an angle of the burr that actually decreases the overhang. So there's definitely an opportunity here for us to discuss what happens when we remove amalgam adjacent to a lot of periodontal tissue. Again, we're not going to get into the conversation about whether mercury in the form of dental amalgam is toxic to the human. The jury's still out in my world whether it's relevant or not. I think the literature has a lot of black holes when it comes to studying that. I personally wouldn't want a bolus of amalgam entering my bloodstream if this was reduced. So I think this is a high risk situation to cause an overload of metals within the bloodstream in a short amount of time. So if this were mine, I would want it removed in a more kind of direct access through the occlusal than through reduction and introduction of these metals into the bloodstream. But it is an option. What if we replace the amalgam with another amalgam? So we create an occlusal access, which in hindsight might have been a better option for the dentist to create a good restoration. I like amalgam in deep situations like this, and I think many of us would agree, especially those of us that have been trained in the era of amalgam. I would feel very comfortable with replacing it with a more better adapted restoration. We could remove the amalgam and then do a resin or modified glass ionomer or glass ionomer. Many of us know this as the open sandwich technique. One could argue that it's hard to get back there, but let's just say for the sake of conversation that there's definitely the ability to access this area. What if we crown the entire tooth? So we get rid of the amalgam and then we place the distal margin down here. We'll call that the crown margin on root option. But we also have the margin elevation option, which would be to remove the amalgam and then restore this entire area with a glass ionomer or resin modified glass ionomer, and then crowning the tooth. 10 years ago, 15 years ago, it was rather taboo to even consider the margin elevation option. But it's showing up more in the literature, and it's showing up more in the lecture circuits where you have world-class clinicians deciding to use this option under the right circumstances. And I would be very comfortable if I had to show up in front of the board choosing this option and defending why I chose this option based upon the patient's presentation. Let's take a look at the concept of restoratively generated treatment planning. What does that concept mean? We tend to use that in the world of implants, but when it comes to thinking with the end in mind, one could apply that concept here. When we prepare a tooth, the majority of us are likely to reduce the tooth structure during our crown preparation based upon where we start. We'll reduce 1 millimeter, 2 millimeters, depending upon our restorative material, and that's it. In other words, we're preparing the tooth with the intention of replacing the contours of that tooth with our indirect restoration. But if we think about the bulbous nature of this tooth and where the food impaction might exist when we're done, I would be more likely to want to create a crown that follows this yellow dotted line. So a more vertical appearance to the crown. Well, if that's true, the amount of tooth structure I'm going to have to reduce is going to have to go all the way to this blue line, which is the anticipated prep or crown prep. So if we think about how much we're going to have to reduce here, this distal is going to require a lot of reduction. And if we think about this in our mind's eye, we're more likely to properly reduce the tooth than if we were to use our normal techniques where we reduce from where we started. We know that wax ups in the anterior during aesthetic cases where the wax up gives us the end result changes our prep design than if we were to prepare the teeth based upon where they started. So we use this concept a lot in anterior aesthetic workups, but in the posterior, it's not something that commonly shows up. This would be one of those times. So what other options do we have? Well, we could look at some perio-restorative options. This yellow line is where the soft tissue is based upon my interpretation of the radiograph. As we can see here, we're existing pretty low underneath the gum tissue or the gingiva or the mucosa. As we know back here, it's not too uncommon where we're actually going to have mucosa or non-keratinized tissue, which should play a role in our decision-making process, as non-keratinized tissue is not as stable as keratinized tissue. If you've never really taken a look back here on the distal buccal of a second molar, you'd be surprised how many times there's a lack of keratinized tissue or minimal keratinized tissue in that area. Well, that would play a role here. So one option in the perio-restorative realm might be the no treatment, wait and see option. If there's no bleeding on probing, no inflammation around this, no decay, no resorption, I don't think that's a bad option. Just monitor the tooth over time. Personally, that's not what I would want if it were my tooth, in great part because if and when this starts to unravel, it's going to unravel fast and unravel ugly. So the wait and see approach isn't necessarily favorable based upon the fact that if and when a problem arises, it's going to be a rather significant problem. Rather get to it beforehand. Gingivectomy. So the gingivectomy could be a standalone treatment where we just reduce this mucosa. I'm going to call it mucosa, just assuming that there's no keratinized tissue back here. Gingivectomy to gain better access to that area, and then maybe we reduce the amalgam after, or we just leave the amalgam there. But a gingivectomy, in essence, would be a tool in the toolbox as we apply these different restorative solutions. What about guided tissue regeneration? It wouldn't work here. And the reason for that is guided tissue regeneration, first and foremost, is a rather technically demanding procedure that really should be done in the hands of a periodontist or skilled surgeon. Yes, that can be a general dentist, but a general dentist that has a lot of training in advanced surgical techniques. But even in the best clinicians' hands, guided tissue regeneration back here, where we're actually hoping to either regrow bone or regrow attached tissue, is just rather unlikely. Guided tissue regeneration tends to work well in defects where, let's just say that this tooth had a vertical defect that looked like this, where the angle from the root surface to the crest of the adjacent tooth was less than 45 degrees. Those are vertical defects or infrabony defects that are likely to regenerate with GTR. Not these horizontal defects where we really don't have any, one, support, but two, blood supply to kind of nourish the bone graft in this area. So GTR in this case, definitely not an option, but something worthy of consideration or discussion. And then taking one from the old perio-restorative realm, back before the days of implants, this would probably be something that would be considered in a situation like this, where the tooth is sectioned like so, the distal root is removed, the mesial roots or the mesial root canals are treated with endodontic treatment, and then a crown placed on the top. So I've seen it done. I've seen it done well, and I've seen it last. But in the era of dental implants and more advanced perio-restorative solutions, I don't think it's something that we should really consider more than just a cool idea. With that said, if there was a large amount of defect here, a carious lesion, a distal abscess that further compromised the distal aspect of the tooth, I might consider it. Implant might be better, but then again, is an implant an option when you have bone all the way down here? Once this tooth comes out, this bone is going to reapproximate probably, you split the difference between here and here, the bone is probably going to look like this. We have the inferior alveolar nerve here. So maybe a root hemisection is a good option when we're thinking with the end in mind. Taking a tooth out and putting an implant in is great if the bone was up here, which it's not. Just another option. So yeah, extraction, we could do extraction with no treatment. I don't like that idea. And if I was going to extract, I would, even if we're going to do no treatment, I would strongly recommend a socket preservation to try to preserve as much of the bone on the distal part of this root to increase the prognosis of this tooth. So we know when we extract teeth, depending upon the size of the current defect and the hole that's left over after the extraction, that we may get aggressive bone loss. And I can just say that based upon how lopsided this is, that future bone loss adjacent on the distal part of that number 30 is likely, and we should build that into the equation of what we decide to do. All the more reason to try to save this tooth, but also maybe considering that root hemisection option, or consider doing a socket preservation, which gives us a better chance of trying to preserve this bone. So what is a recommended solution? Again, we talked about the fact that this kind of clinical presentation, if presented to 100 dentists, is going to likely result in many different opinions. This is just what I think based upon my 17 years as a dentist and seeing things work and not work in my hands. This is what I would recommend for this patient. Now, this is my recommendation in the absence of patient poor compliance and in the absence of patient financial constraints. I'm going to talk a little bit about what I would call a cost-conscious solution next, but let's start with what the ideal solution would be from my vantage point. The first thing I would do is a distal wedge gingivectomy, and these can be rather tricky, especially if there's non-keratinized tissue back here. On the lingual, we have the lingual artery. There are muscles in this area, so it's a technically demanding area to do, especially if it's not highly keratinized tissue, which I'm assuming it's not. So this might be a gingivectomy that we want to refer to the periodontist. So a distal wedge gingivectomy might be an easy procedure. This is one where it's probably not super straightforward. But I would make sure that that's done. And then I would remove the amalgam and replace it with a glass ionomer or resin-modified glass ionomer, and then make sure I have an impeccable margin from the root to restoration. So this zone right here, I'd want to make sure is rather smooth. Best way to do that, one, is remove all this, and two, make sure the tissue is out of the way so that I can see or at least feel this junctional interface to make sure it's nice and smooth. Then I would use the margin elevation technique, where I would, in essence, place the crown some distance away from the glass ionomer. It would greatly depend upon where this margin lives after the gingivectomy. Might be possible that after the gingivectomy, this is actually super gingival, in which case you don't need to do margin elevation. But let's just say that this yellow line reapproximates to here. I would feel more comfortable leaving this area as a resin-modified glass ionomer, in great part because I'm not likely to get a good impression down here if this was subgingival. So again, margin elevation technique with a crown, something I'd be very comfortable defending if something were to go wrong. But that's really up to you to decide whether or not you feel like the standard of care would be violated or not. And if it were violated, could you make a case that it was the right decision nonetheless? At the end of the day, I feel like when I treat patients, if I'm going to live outside the standard of care, our job is to properly educate the patient on that fact, why we're choosing that decision, and what the pros and the cons and the risks and benefits are. And if we properly document that and the patient's on board, I would find it hard for a dental board to consider a practicing dentist in violation of the standard of care under those circumstances. But proceed as you wish. And then lastly, designing this crown without that bulbous nature back here. We looked at what that crown design is. Essentially, we want this as vertical as possible. The final restoration as vertical as possible to decrease food entrapment back here, but also to increase the ability of the patient to brush and floss in that distal area. All right, so that's the recommended solution. Again, there's probably several ways to change this, but in a nutshell, this would be what I would consider ideal and what I would want done for me if this were my tooth. But what about the patient that doesn't have the money, their insurance plan doesn't cover gingivectomies, something along those lines? I think we're all familiar with these scenarios. So I'm going to call this the cost-conscious solution. We might also call this the solution for the patient who's non-compliant, in great part because we're trying to do everything all in one appointment. We have them there. We just want to give them a solution that they can go home with and give us the best long-term stability. I'm going to call this the resin occlusal onlay with an RMGI open sandwich technique. So the first step would be to remove the amalgam. Again, we're going to be removing the amalgam through access through the occlusal. I think accessing through the occlusal would be a necessary sacrifice for us to make in order to access this appropriately. We would then create a modified Toffel-Meyer band to attempt isolation on the distal. So using I think everybody would know what I'm getting at here. So modify an occlusal or a Toffel-Meyer band to get down in there. And then we would restore with an RMGI or glass ionomer. One might say glass ionomer is more favorable here. In my hands, I've placed RMGI as very subgingival and had great success with it, as long as I'm not invading the biologic width, which is really not part of the conversation here, great part because the bone is so far away from where we're going to be restoring. And then we're going to cap the occlusal surface with composite as an occlusal onlay. So this yellow border is essentially where I'd be placing my RMGI, and then the blue area is where I'd be placing the occlusal composite as an occlusal onlay. You can call it a build-up, you can call it a MODBL, but in a nutshell, this technique I often use with endo-treated molars and really many endo-treated teeth. And the reason is when the patient bites down, they're going to be essentially biting down on this entire occlusal surface of resin, which will direct forces straight down the tooth, which would act favorably from a biomechanical perspective because resin does rather good under compressive forces. So does the resin interface. But if we say built this entire thing up with RMGI, RMGI, one, isn't as abrasive resistant as resin, but also the likelihood of this debonding because of the vertical component of the restoration here, when a patient bites down, this surface would be under tensile stress, which would increase the likelihood that we get debonding or micro leakage long term. So we're using a more biologically sound material or restoration here, and a more biomechanically sound restoration on the top. We do all of this, if the patient's an insurance patient, we're charging out essentially a 4-surface composite. Not a lot of work for very low reimbursement, but this would be the option if you felt bad for the patient, you wanted to give them something. I really like the previous option for the long term. I can tell you that if you decided to do this and maybe someday crown it, 99% of patients aren't going to do that. That's just based upon my patient pool and my experience. So if I chose this, it would be because they're just not going to do the crown. If they're going to do the crown, I'm billing out everything at the same time to make sure that they're going to do this option here, which I don't have any fancy artwork for, but I think we can picture in our mind's eye what I was talking about. So that's the case of the week, number 3. Again, Mitch, thank you for sending this case. When you sent it to me, I instantly thought this would be a really good NECADE session for us to unpack together. For those watching the video on the YouTube channel, I would love for you guys to, pick my solution apart or provide some alternative solutions that I didn't provide here. And what would you do based upon the fact that the patient is compliant and or non-compliant and financially able and or financially unable? So additional insight would be well received, and let's share with the rest of the world what we would do. And in the process, we all get to learn together. Hope everybody has a good day, and thanks for watching.